I request Bharti to start her talk while Hari can get ready. Dr. Shinoy can. Bharti, can you share your screen, please?
Sure. You see my screen, okay?
Yes.
Yeah, perfect. All right, thank you so much for giving me this opportunity. I'm very thankful to AIOS and ASPOS both, and then my close friend Sumita for giving me this invitation. So I'll be talking about pediatric cataract, what I've been doing different in 2022. And since then, I have no financial disclosure, but we were a site for trivial therapeutics, and you'll know why I'm mentioning this at this point. So what I did differently, I was trying to think. So I have broken it down into little subheadings: pre-op evaluation, the IOL power calculation, and then the surgical technique, how it has differed in the past year. So starting with pre-op, so I had this 22-month-old boy who was referred for evaluation of bilateral cataract diagnosed by his pediatrician. He was otherwise healthy, full-term baby. Mom had, so family history was significant for mom being recently diagnosed with cataracts, and she was told it was kind of a congenital cataract, but she has had no surgery. She's in her 30s, and then grandmother had her surgeries in 50s, and mom is pregnant at this time, and she is really worried, what's the chance of my second child having the cataract too? And since we all know it is transmitted autosomal dominant. So you can see at bilateral cataracts, left greater than right. So maybe they were hereditary cataracts. I didn't really know. So mom really wanted like testing to investigate what we should do. So as we all know, for unilateral cataracts, we don't need any pre-op testing or evaluation because it is believed to be from localized dysgenesis in the eye. For bilateral cataract, I would say half of the patients we can identify some cause. They either have some known syndrome, genetic mutation, treatment for cancer, steroid treatment, something that you can attribute to be responsible for bilateral cataract. But then comes the hereditary cataract, where there would be some family member. I would say about 20-25% they are hereditary cataracts, and rest are probably idiopathic, which in our study was about 35%. So now we have an option of some genetic testing available for these patients. And as I said, these bilateral idiopathic are the one that needs systemic evaluation. And then the hereditary, if the family is really interested, we could offer a genetic testing for them. So we do a complete pediatric physical exam. We do send some labs. So in US, we do have like a basic newborn screening, which screens for about 30 metabolic disorders. So we just go through them and make sure there's nothing that's positive out there that was missed. We do check for glucose, basic metabolic profile. Probably talk titers are going to be important in the Asia Pacific region, which we don't encounter so much in US. And then we do refer to genetics if the family was interested. So we were part of this trial called Behind the Blur Early Onset Bilateral Cataract Genetic Test Program. So they have a kit that basically tests for 66 genes. So this was basically offered to the acquired cataracts. And then it was free for us just because we were part of the trial, but it is commercially available too. And I'm going to let you know how we can access that. There is a congenital cataract panel, which can test for 41 genes. If the onset is unclear, then there's a comprehensive cataract panel, which tests for about 171 genes. And then there's an anterior segment dysgenesis panel, if you notice microphthalmia or anterior segment dysgenesis. So we usually order it through the preventive genetics. I have no financial disclosure, but that's how we offer. And most of these are somewhere from $800 to $1,200, but it's we usually submit it to the insurance companies, and many of these, if you give them a letter of medical necessity, they do get covered. And then the way they are tested is we basically collect the blood, saliva, or buccal mucosa. Once you fill out the form online, they usually ship it to the family or directly to the physician, and then the turnaround time is about a month. So that's something new that we have been doing in the pre-op evaluation. Coming to IOL power calculation, as we all know, for younger children, we do biometry under anesthesia, but anybody who can sit behind the IOL master, I still prefer IOL master. As we all know, it's much more reliable. There's better fixation, better numbers out there. And then we undercorrect depending on the age at surgery. But we can still see how much myopic shift happens. This was from one of our study that was published of about 200 patients over a long follow-up of 20-25 years. So we tried to understand it better. So we studied our normative patients and then studied the biometry, because there have been no studies since Gordon and Donzis. And then we compared them with the cataract size. And then we were trying to understand what will be the implications on post-op target and IOL power selection. As we all know, the age and the axial length, they probably matter, and we already follow the undercorrection criteria depending on age at surgery. We typically aim for emetropia around 6 to 7 years of age. But in this study, we did find that the steeper keratometry was also a contributing factor for myopic progression. So we did add a little more undercorrection for patients who had steeper keratometry less than 42.25. So that's a new change we have done. And this is the table from our paper out there. The other new thing that we have been doing is there were a couple of studies last year showing the efficacy of Barrett Universal 2 formula, which is widely used in the adult population, but it has been shown to be more predictable in our pediatric population, showing a smaller absolute prediction error. So that's the other additional thing that we have been trying. We have the new IOL Master, which gives us the option versus there are online Barrett calculators, which you can access, and then you just feed in the information online. It doesn't save any information, but you can print out your copy. The only additional thing it still needs is white to white distance, length, thickness, ACD, predict the refractive error, and then the K and axial length as we normally do. We don't have our data yet, but we have been studying it in the past year. For the surgical technique, I think there has not been much changes in the technique itself. What we usually do is use vitrectorexis in very young children up to age 2. Anybody after age 2 gets a manual ACCC. Probably we have evolved that because we have a lot of fellows that are trained with us. We do have primary management of posterior capsule and vitreous in first 6 to 7 years of life. Closed chamber technique, bimanual techniques, viscoelastic, good cohesive viscoelastic is a must. We do use a little bit of visco just to protect that endothelium because they have a long life to live. And then very important to close all those wounds in pediatric population. So this was an interesting boy who came in, like he's a 7-year-old boy who was referred for his right eye cataract surgery. He has history of glasses since age 3, anisometropic amblyopia, patching, atropine, penalization. He was diagnosed with cataract in past year and a half, but it had progressed. That's how he was referred. He did so on further questioning. When I dilated the pupil, it looked very unusual kind of cataract. I did question more. So he did have history of trauma, which he endorsed on the medial side of his right eyebrow, but then it didn't require any suturing or anything for him. So when I took him for surgery, as you can see, what we usually do is we do 2 side port incisions, and then we do the rexis using the intraocular forceps. And then when we usually use the vitrectome and then irrigation port, and then try to separate that lens material in all the quadrants, as you can see. And then finally we went towards that quadrant where you can see that little I thought it might be a posterior capsule plaque, but you can see once we pulled it out, there was a pre-existing defect right there. So probably this was a congenital cataract. He was referred as a traumatic cataract. And then we injected the viscoat right there to seal. that area, we could aspirate rest of the lens material, did a good vitrectomy, and then inserted the lens. You can see we inserted it through the nasal aspect. So we didn't want the leading haptic going in that posterior capsule opening there. So that's how we opened up the nasal aspect and injected the IOL, probably the basic principle that we all would use. But looking back, I would think I hadn't expected a pre-existing defect in this one. What I would have done differently was probably aspirated all the lens material before going in that quadrant and pulling it out. This was probably a little more stressful for us because there was a big opening right there. We were really worried that the lens material might drop. This was another kid, 14-month-old, very complicated medical history, referred for bilateral mature cataracts. He was a patient of mine with no cataracts, and within a month, he developed like those mature cataracts. Again, we used the same technique, but because he was a young child, he did need primary management of posterior capsule. So what we usually do is we use a trocar right at the beginning of the surgery. We insert that trocar, and then we finish the front part of the surgery. So what we did was did the vitrectorexis, remove the lens material, put the IOL in. As you can see, the IOL is already in there. And then we go through that side port incision through that trocar, and then with the irrigation port in the anterior chamber, and then usually do the posterior capsulorhexis and the vitrectomy. We think it's a safer technique just because we have fellows, so we know the IOL is in the back before we go to the back. But this kid, you can see once. So what I did was close the incision partly so it doesn't allow too much of fluid leakage, and then we went and did the PCC. And then we were trying to do the vitrectomy. That's when you can see the eye is really getting softer and softer, which was very unusual. You can see those folds forming near that trocar as if the globe is kind of collapsing. I was really concerned. So we somehow finished the vitrectomy because we were really worried about it. And then pulled it out, but probably what was happening was we didn't remove the viscoelastic from the anterior chamber before we did that, and there was little viscoat and lot of provisc sitting there, so it didn't allow the fluid to go to the back. So that's the reason there was an imbalance between the irrigation and aspiration that was happening. So there was not enough irrigation, and we were aspirating the stuff out, which probably caused the collapse. We did check his retina at the end. There was no retinal detachment. We put an air in, we sutured it well. Next day, the IOP was 15, but that time it was like really soft globe, which was kind of scary for us. So that's what I have changed. I usually aspirate the lens material, put some pre-placed sutures, and then go in and do the vitrectomy. We do use intracameral moxifloxacin at the end of the procedure. The other new thing that we have started doing is we used to use the subconj DEXA for a very long time. We have switched to intracameral DEXA for all these patients. It's a preservative-free. We have been using intracameral triacins at the end of surgery, about 4 milligram, 0.1 ml. So this way we give lower frequency of eye drops to the family, especially useful for kids with cerebral palsy or developmental delays, where it could be very challenging to get the drops in the eyes. We have been involved with this trial with Dextenza, which is a dexamethasone intracanalicular implant. So basically, you can see the picture right there. What we do is dilate the punctum. We insert that dexamethasone insert there and leave it there. So once you make sure you dry it before we put it in. So once you put it in, it kind of swells with the moisture and then fits comfortably and securely in there. It releases steroid for about 30 days and then reabsorbs and exits the canaliculus without the need for removal. The only thing is the cost factor. It's pretty expensive. It's about $600 for us. So we have been using it as part of the trial. If given an option, probably I would still go with triacins. With that small amount, it's usually helpful and it's much more cheaper for us. So these are some of the changes we have made in the past year. Thank you so much again for giving me this opportunity.